Hello, I'm Kimberly Greer from EmergeOrtho-Triangle Region's marketing team. I'm joined today by Dr. Aldridge, orthopedic surgeon specializing in the hand and upper extremity. Today we are going to be talking about Dupuytrens and some of the most common questions that he receives from his patients. Okay, so first, Dr. Aldridge, tell us a little bit about how you got into the specialty of the hand and upper extremity.
Great, thanks, Kimberly. It was a natural choice for me. My exposure to orthopedics in general was through work I did in a hand surgery lab. So early exposure to the field of hand surgery really piqued my interest in it. And then once I got deeper into it, I recognized that it allowed me treating patients of all ages. So we treat, newborns with congenital hand defects all the way to patients over 100 years of age with either trauma or arthritis, and then all ages in between. So there's a wide variety of ages and a wide variety of pathology, and that variability keeps my interest up.
Wonderful. All right, so we'll start off with a few of our questions. So what is Dupuytrens?
So Dupuytren's contracture is a condition that develops in both men and female. It has a predilection for men, almost 15-1 over women. Women can get it. It is typically painless. It's a thickening of the palmar fascia, the fascia being the layer of tissue directly underneath our skin. That particular fascia is called the palmar aponeurosis. It's unique to the palms of the hands, and it's also on the soles of the feet, and it acts somewhat as a securing anchor between the skin and the underlying tissues, which is a evolutionary adaptation because we walk on our feet and get up on our hands and so forth. So stabilizes the skin. That tissue, for reasons that we understand the working pieces of it, but not how it all comes together and is manifest physically, but it tends to be onset by inflammation. Average age of onset is usually 55. And again, has a predilection for males over females. And again, I've already said it, but worth repeating that it's usually painless. And so if you have a painful bump in your palm, it's usually not Dupuytren's.
Gotcha. Okay. So what causes Dupuytren's?
Well, again, we don't really know what the actual cause of it is. We know a lot of associations with it. We know, obviously, male gender, as I've said, history of a heart attack, alcoholism, smoking, trauma, all have a loose association with it, but none of them are singularly causative of it. It is genetic, has a strong inheritable trait. So if a father has it or a brother has it, the odds are that you as a male are going to develop it at some point. Another interesting feature of it that is almost without exception is that there's almost a 90% incidence of Northern European heritage. So I would say the top 3 countries of origin would be Scotland, Ireland, and some of the Scandinavian countries. Germany's up there as well. But people who develop this, if they aren't aware of their heritage, would trace it back and more likely than not find that it is linked to one of those countries.
Interesting. Oh no,
it felt that it's related back to Eric the Red, the Viking. And so you may see online, it's somewhat colloquially referred to as Viking's disease, and that's for it. And so it was felt that as he worked his way down the shorelines of those countries, conquering towns, he spread the disease.
Oh no. Well, that answers my next question of if there's any cause and effect between Dupuytren's and anything else. So what are the typical symptoms of Dupuytren's?
So the number one symptom is going to be the development of a contracture. Again, typically painless. So if the patient's palm, which is this side of the hand, develops some thickening in these areas of the fingers, and the fingers begin to draw up. So the patients will always be able to make a fist. It's that when they go to extend their hand, they can't open that finger up like we normally can. So they can make a full fist, but they have a contracture of the hand. That is the a feature that everyone has.
Okay. So how can that be treated?
Well, if it's just the thickening, painless thickening or cord without contracture, we don't recommend any treatment.
Okay.
If it is a cord with contracture, then that is typically treated, and it can be done so several ways. Simply put, surgically and then non-surgically. Within the non-surgical treatment limb, that can be done with Xiaflex, which is the enzymatic degradation of the cord. So it's a commercially available injection. It's an enzyme that's been harvested from a bacteria. It's not an actual bacteria that's injected, just the enzyme. And then there's another procedure called a needle aponeurotomy, which is where the skin is anesthetized with lidocaine so that the patients don't feel anything.
Mm-hmm.
And then a needle is introduced through the skin into the cord in a repeated manner, similar to a sewing machine needle going up and down. And that's done basically scoring the cord until it weakens, and then you apply pressure to the finger, and it can be fractionally lengthened, and then the finger subsequently extended. The two non-surgical methods I just described, their obvious benefit is they're not surgery, so they can be done in the office. There's no incision to worry about healing. They really don't need to do any physical therapy to get their grip back. That's not compromised. The downside, though, is that they're going to have a higher rate of recurrence and a quicker rate of recurrence. But for many, the conveniences of no surgery are worth the risk of recurrence, because it can certainly be repeated.
Mm-hmm.
If it comes back every year or two, you can repeat those procedures every year or two. Conversely, surgery, which is a more dramatic intervention,
right,
does have an incision and requires therapy almost invariably. You get a more complete removal of the pathology. You may get a more complete correction of the contracture. And because you have removed the pathologic fascia, the recurrence rate for the surgery intervention is much lower. But the point should be made that regardless of what procedure you have, be it surgical or non-surgical,
mm-hmm.
there is an unacceptably high rate of recurrence that we can't avoid as treating surgeons. That's the only frustrating part of it. It's not a guarantee that it will recur. I've treated many patients now, almost 20 years out, who I see and they've had no recurrence, but it's not uncommon for it to recur.
Gotcha. What would happen long term if there was no treatment?
So the contracture develops and is progressive. So it can get rather dramatic to the point where the finger that's contracting is almost clasped in the hand.
Mm-hmm.
And it gets very difficult for patients with Dupuytrens with dramatic contracture. If the finger's bent down like this,
Mm-hmm.
it's hard to get your hand. It's impossible to get in a glove. It's difficult to put your hand in your pants pocket. It's difficult to wash your face. It's difficult to hold change in your hand. So it's not a painful problem, but it just becomes increasingly dysfunctional for the patient.
Right. Hard to perform daily activities.
Very much so.
Gotcha. Alrighty. Well, thank you, Dr. Aldridge, for joining me today. If you viewers would like to learn more about Dr. Aldridge, I will be linking his bio in the description below. You can use that link to request an appointment with him or book an appointment online. Thank you so much for watching, and we will see you next time.